Okay, thank you very much. So wanted to kick off this session and touch on some of the topics, some of which we had been broached before, but returning back to this framework that I'd started with in the morning, and really understanding the currently defined standard of care molecular subsets, and then I'll come back and talk about some of the upcoming ones as well. So the first is, of course, the very tough area of RAS mutation. And I just want to make one comment here. We'll hear about novel areas in immunotherapy where this may be relevant. But one thing that commonly comes up, and I'll get emails sometimes about this, is this idea of, besides those RAS mutations that are in the guidelines, what else should I be worried about? Right? And so we know that it's not common, but maybe 1 to 1.5% of patients will have one of those other RAS mutations, either in KRAS or NRAS, that are not in the guidelines. And so I wanted to spend a minute on that, just to reiterate that this is really one of these challenges of precision medicine. How do you go from, how do you show in a prospective, predictive way a impact of something that has such a rare incidence? But ultimately, as clinicians, we have to make a decision on the patient in front of us. And so, for example, if you have a patient who comes in with a KRAS in codon mutation in codon 22, what do you do, right? And I'm sure a lot of us have had situations like this. So just mentioning that there is a lot of heterogeneity, and this is a busy slide, but these bars are just showing degree of signaling activity, and you can see that that compared to the areas that are highlighted, which are the guideline mutations, that there are a number of other alterations that indeed can also increase signaling. So just as we're trying to provide the best care for patients, just remember that there are a few, and I'd actually highlight 4 of them that have really demonstrated significant, or 5 of them that had demonstrated significant activation of that to think about. So just be aware of this. It's sometimes worth kind of seeking out some additional information to try to understand that. And I'm certainly happy to help share and circulate some of the data that we've generated to help with this as well. But we've also recognized that this degree of RAS activation, how much the RAS mutation actually activates the MAP kinase signaling, may be clinically relevant. Not clinically actionable necessarily, but this is just showing even when you look at the standard RAS mutations, we can categorize those RAS mutations as higher degree of MAP kinase pathway activating and lower. And actually what you can see here is that their survival is different even within the RAS mutated group. So this idea that all RAS are the same is still true when we're making clinical decisions, but just be aware that there is some clinical heterogeneity in these subgroups. And I think this is going to be an area that we'll see additional developments moving forward, because a lot of the novel therapies for RAS are starting to target particular subgroups of RAS. For example, G12C mutation inhibitors, they're making use of the cysteine binding. So we talked earlier about BRAF, and we also have touched a little bit on MSI high, but I think just worth reiterating this point, and you'll hear more in the afternoon sessions about immunotherapy, about MSI high from Neil. This is curves you've seen already, just reminding you that PD-1 inhibitor activity has been limited to the MSI high patients, and these are the curves dramatically showing that. But also that nivolumab, either alone as a other alternate or in combination with ipilimumab, which is not a standard approach, not on guidelines, but where there is at least a numerically higher response rate. And I think for all of these, and I apologize that the slide got shifted up here, the title here is good durability, and that, as Neil mentioned before, is so critical, right? So we shouldn't be evaluating these agents necessarily on their response rates, although they're high, but really this durability, and especially when we, there's some cross cohort comparison here a little bit, but this idea that we can get a fairly good disease control rate and really impressive overall survival. 60% survival with Nivo alone at 30 months in the data that we presented. So just that background to highlight ongoing efforts in the cooperative group setting here in the U.S. This is the NRG GI 004 SWOG S1610. It rolls right off the tongue, right? So we do need to come up with an acronym. So commit, there we go. I can't remember what commit stands for, so Howard will have to remind us. Something, colon mismatch, yes, exactly. Thank you. So this is a randomized first-line study. So we know that MSI in second line and beyond is approved in the guidelines. This is now looking at it in first line with or without chemotherapy. And then in the adjuvant setting as well. So the atomic one, the atomic study, and this is run by the Alliance. Really encourage everyone to participate in this as well. This allows a little bit of time for you to figure out the MSI status. As Kathy mentioned before, sometimes we don't have tissue available right away, and it takes some time. We've got to get the patient started on treatment while we're figuring out the biomarkers. So this study allows you to get a cycle in, and MSI patients then go on to get FOLFOX and Atezo for a total of 12 months of Atezo versus FOLFOX alone. So we've heard a good discussion about the use of EGFR inhibitors in left or right-sided therapy, and just showing my current practice patterns here. But I think the key is, how do we move this forward? And I just wanted to highlight one area of interest, which is that we know that this resistance that develops to an EGFR inhibitor can be quantified, and we can identify a number of alterations. And this bubble plot on the right is just showing the different types of alterations proportionally that are seen. Majority of them are acquisitions of KRAS or NRAS mutations, as the group knows. So the intriguing question is, what do you do with this? And one of the key findings has been that these resistance mutations actually do regress over time, so that when we remove the selective pressure of the EGFR inhibitor, this is work from a fellow, soon-to-be junior faculty at our institution, Christine Parsigian, that shows that these mutant clones regress with a half-life of about 3 to 5 months, depending on the particular alteration. So given enough time, these clones can regress, and then the idea is that then there's an opportunity, and these are research questions still, to re-challenge. And I show the phase 2 cricket study, which took responders and then treated them with a re-challenge, and you can see that you can indeed re-induce a response in that setting. So some of the randomized studies that are being done now in Europe, for example, starting with an EGFR inhibitor, going to an alternate agent, bevacizumab, and then randomizing to return patients in third or fourth line to an EGFR inhibitor, recognizing that some of these clones at that point may have regressed and there may be a benefit for rechallenge. This is still experimental, and we'll have to really more robustly define this. But I think it's really nicely been integrated, and we can see a lot by our ability to monitor this. And you'll hear more from John Strickler later in the afternoon about circulating tumor DNA, which is really what has enabled these type of work. So there are studies ongoing. Here are just two of several in this area, which says, well, maybe we can use alternate agents in this resistance. So there's a SIM004, which is an EGFR monoclonal antibody combination that's showing some benefit, and then a combination of panitumumab and trametinib, where we're seeing clinical benefit in patients who have RAS, acquired RAS after EGFR inhibition. So those, again, remain a bit experimental, but I also wanted to touch on a few other novel subgroups. And you've heard some of this already. And the first one I wanted to talk about was HER2 amplification. And I would echo what Axel said earlier, which is this idea that HER2 is kind of the next biomarker that we're going to see probably move in because it has this predictive and prognostic importance. So HER2 amplification. So it's present in somewhere between 3 and 4% of colon cancer. And again, reiterating the point that especially when you are picking patients who are RAS wild type, who haven't responded to EGFR inhibitors, for example, who are more predominantly left-sided in the colon, these are ones that you can see these HER2 amplification rates go up to even 20% and beyond when you are narrowing down this very unique group. So the assay can be done based on immunohistochemistry. It looks like that anything that's 3+ would be considered amplified. 2+, the suggestion is to get FISH to confirm amplification. So, so this is work from Conwell Rogoff at our institution, but I think also has been seen in other settings as well. But this is now looking at EGFR-based regimens. So biologically, it makes sense when you have a HER2 amplification that you're not as sensitive to an EGFR inhibition. So it checks the box of biologic plausibility. And what you can see here are curves with two different cohorts between a HER2 amplified or non-amplified within EGFR-based regimens. And of course, this is a non-randomized setting, so the question is this predictive or prognostic? But when we look at chemotherapy with in first-line setting where there was not EGFR inhibitor utilized, you can see that those curves do not separate, so that suggests, although you still need large randomized studies to demonstrate that this is indeed a predictive biomarker as you would anticipate biologically. So, so I think we'll be seeing analyses coming out of 80405 and others that will really be adequately powered to really understand and nail down this idea of it being a predictive marker for EGFR-based regimens. But the excitement of HER2 is obviously the novel therapies that then you can use as a result of that. And we'll hear some data from Andrea, as was mentioned, coming up a little later this year. But here's the trastuzumab lapatinib data, the Heracles study. So this was done in Europe. Response rates here, 32% with trastuzumab and lapatinib combination in the HER2 2+ and 3+. The higher amount of amplification you have, the greater the benefit. So it does appear to be a correlation. The My Pathway study, the Genentech-sponsored basket study, had colorectal cancer patients in it, and these are the colorectal data, trastuzumab and pertuzumab in HER2 amplified. Response rate here, 38%, and you can see that the progression-free survival. And it does look like that KRAS, although KRAS is usually somewhat mutually exclusive with HER2, but it looks like that there can be some impact there. And you can see the little Ks for those of you in the front two rows or those that are looking on the screen. Apologize for the small size, but the Ks there are ones that had the concurrent KRAS. So this has been a lot of enthusiasm for this, and this led to the SWOG 1613 study run by Dr. Conwell Rogoff and Howard Hochster as the leader of the GI group for SWOG. Exciting thing here is this ability to provide central screening for HER2, really a simple screening consent form that can be done at any point for the patient, and the RAS wild type patients in second or third line setting can then be randomized to a standard of care cetuximab arm or the trastuzumab pertuzumab. And the endpoint here is progression-free survival. Patients on the control arm can then cross over to receive the combination. So this is one that we're very excited about. I think both a lot of data about the high level of activity with the intervention arm, but also that the control arm may not be as active as we'd like in this particular subgroup. And so, so really encourage everyone to open this and enroll if available. So this was mentioned earlier by Andrea and Axel in the discussion. What about HER2 mutations, right? we actually see them. It's seen in 2% or so. We get it on the reports that come back. Certainly looks intriguing, looks like something that we should be able to target. What's the data? Well, this is some nice data is presented, now published. And what you can see is that the waterfall plots by tumor types, look at that encouraging waterfall plot for breast cancer, certainly some activity in others, but colorectal cancer, again, this is another story of tumor histology matters when we're talking about targeting some of these alterations. What you can see is that none of the colorectal cancer patients responded, not even a minor response that was seen. And so this is clearly a bit of a warning sign that this strategy is not working in colorectal cancer. Why is that? Well, there is an association with MSIH, which implies that some of these may be passenger mutations, right, just a higher mutation burden, and the distribution of some of these may not necessarily lend themselves to be drivers. But even when it is a clear activating alteration, there does not appear to be notable activity with the TKIs. So intriguing as it may be to try to pursue that, I think at least as a single agent TKI, it's not something that I would recommend for patients at the moment. Now, we always chase these mutations, and I think one of the things to reiterate is that there is a long tail of mutations, and so there are certainly still other things and other low-frequency molecular alterations. And while many are not actionable, there may still be some subgroups defined. One of the ones way down at the tail are fusion products. Now, fusion alterations are really intriguing because they are much more likely to be driver events. And it is such a profound derangement of the cell signaling when you get these fusion events that a lot of times that this can be very actionable. So one is the TRK family. So this is the TRKs play a role in a number of things that aren't necessarily aren't necessarily activated normally in colon cancer, but when it's bound to a fusion partner, you get ligand-independent activation, overexpression, and you really get high activity of the kinase domain, right? It's really chopped off the regulatory portion of the kinase, and all you have is the engine. It's just continuing to fire. And so the TRK inhibitors then, the larotrectinib development program, is really just showing how hard it is to get these patients because they're fairly rare across many different subtypes. And you can see this was the pre-specified plan that the FDA said this is an acceptable plan for getting this inhibitor approved. They said you can get 55 patients, including some pediatric and some basket patients across histologies that they would consider this for approval. And here's the results, that really impressive waterfall plots for larotrectinib. And you can see the light green, or medium green maybe, there is colon. And certainly the activity is seen in colorectal cancer as well. But you also see pancreas, cholangiopancreatography on that list also. The difficulty is, here's the median progression-free survival. So this point, that's not just response rates, but durability. And this is a 12-month progression-free survival of 63%, which is certainly encouraging. The difficulty is the prevalence. It's extraordinarily rare in colorectal cancer. It's probably in the 0.2% range. And intriguingly, we're starting to see resistance to these inhibitors. This is one report that's come out that actually says that, just like an EGFR inhibitor, you can get these gatekeeper mutations that occur in the NTRK itself and resistance. So while we're seeing good PFS, there are going to be patients that will see breakthrough resistance. Now, there's others as well down in that sub 0.5% range. ALK fusion is another one, and this is just showing a case report of a good response to an ALK fusion as well. There's efforts ongoing because these are so rare, really trying to think about how do you do this and look at many different biomarkers at once. And that's some work by John Strickler, who's leading some of the efforts there. Given that, I think I'll end there in the interest of time, but appreciate everyone's time and attention.